Okay, good morning, good afternoon, good evening po sa lahat. Welcome to the 136th episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and to all those who have just discovered us today, welcome po at sana po masiyahan po kayo at marami po kayong matutunan sa ating special topic for today. Bawat buwan, thousands of Filipinos are able to undergo complex and life-saving surgical procedures dahil po sa anesthesia. Anesthesiology as a branch in a specialty field is considered as one of the most significant breakthroughs of modern medicine. It has enabled various interventions for diagnostic and treatment purposes, from delivering babies to heart transplants. It has made possible to eliminate pain, monitor vital signs, and intervene during critical moments. So for today's webinar, yan po ang ating pag-uusapan at aalamin for today's topic. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Fridays, and looking forward to our Fridays because I get to share hosting duties with our adjunct research faculty at the National Telehealth Center and international renowned public health communications expert, Dr. Susie Pineda Mercado. Dr. Susie? You're on mute, ma'am.
Hi, good afternoon, Raymond. Magandang hapon po sa inyong lahat. And welcome. For a moment, disabled yung chat natin, na-miss ko tuloy. Change natin. Anyway, welcome to everyone who's with us on Zoom. I'd like to welcome all of you who are watching us on YouTube. So the TV UP YouTube channel, as well as the UP System Facebook page and the TV UP Facebook page. So we're on multiple platforms. And of course, we do have a playback on TV UP Signal TV Channel 101. So we have a very exciting topic today. And as always, we try to bring you the best speakers, and you will get a taste of the best speakers in this field today. We will be talking about general anesthesia and developments in putting a patient to sleep. Kaya yung title natin, Raymond, gising na. O masarap bang tulog mo? Kasi what happens to the brain when a person is under general anesthesia? And can patients remember this? So behind the scenes, we're going to hear from some of our leading anesthesiologists. The main presenters are both consultants with the Department of Anesthesiology at the UP Philippine General Hospital. So we have Dr. Antonio Alan S. MANGUBAT, who will discuss sleep and anesthesia. And we have also Dr. ILUMINADA T. CAMAGAY, who will tackle the dynamics of anesthesia and the developing brain. And of course, our reactor will be one of your favorites. You've had her on the show before. We'd like to welcome Dr. Grace Ann HERBOSA, Chair of the Department of Anesthesiology at the UP Philippine General Hospital. And our closing remarks will be delivered by Dr. Dion Sakdalan, PGH Coordinator for Training at the UP PGH. And so now we know that you've been, you're eager to find out what the latest news and developments are in public health and medicine. And it's for this purpose that we bring you the news update.
Okay, for our very first news update po, and scientists really have made breakthroughs, and this time using genetic sequencing to track the source of severe eye infection. So there's a hospital in the United States that has reported the first infection that was determined to be caused by a bacteria called Pseudomonas aeruginosa. That hospital, which was equipped, fortunately, to do advanced genetic testing, they were able to quickly realize that the bacteria had a rare gene that protected it from the effects of commonly used antibiotics. So dito po natin narinig yung mga super bacteria na talagang very, let's say, immune sa certain antibiotics po. Good thing that there was a newer antibiotic that administered intravenously called cefidorocol, which was something that worked against this new super bacteria. And a check of artificial tears brands pointed to one common product called Esricare Artificial Tears, an over-the-counter product marketed in the United States, which has since been recalled by the FDA. So something to think about in terms of really how we could connect yung tong genetic sequencing and help trace and track kung sino man po yung source o kung ano man po yung source ng particular infection. How about you, Dr. Susie?
Well, Raymond, Hong Kong has dropped its mandatory mask mandate, signaling an end to the tough COVID-19 restrictions that disrupted the city's economy and ravaged its tourism industry. As of Wednesday, residents and visitors are no longer required to wear masks indoors or outdoors, although there are some exceptions that have been maintained, such as in hospitals and healthcare facilities for the elderly. Authorities in Hong Kong have enforced one of the longest and strictest mask mandates since the start of the pandemic. And in Hong Kong, it was mandatory to wear a mask for 940 days, and anyone caught breaking the mandate faced on-the-spot fines of 5,000 Hong Kong dollars. At one point, residents were even told to wear masks while exercising outside. But even after this mandate was lifted, we find that the vast majority of people on the streets of Hong Kong continue to wear their masks. And that's the news for today. We'll be back with more news on our news update next week. Okay, and we're back. We have, as mentioned, we actually have a lot of people who have questions around anesthesia. It's always quite challenging for first timers, but we do have a lot of people who've had general anesthesia. So Raymond, let's introduce our person on the street interview.
Thank you, Dr. Susie. And to all those who have just tuned in for the very first time, we usually set our discussion into context by watching this short video produced by the TVUP team, wherein we ask common folks on the street a simple question lang po. And for this week, we asked them, pinatulog na po ba kayo sa pamamagitan ng anesthesia? Ano po ang inyong karanasan tungkol dito? Please watch this.
Oo, nakaranas na akong mapatulog gamit ang anesthesia.
Hindi pa ako napatulog ng anesthesia.
Oo, napatulog na ako ng anesthesia dati. Na-experience ko na yun.
Yes, actually, 2 beses na.
Last 2015, I was diagnosed with thyroid cyst sa aking ovary. So, I had to undergo with surgery. And doon ko nasubukan ang magamitan ng anesthesia.
I think yung first was when naoperahan ako sa neck, and then actually mabilis lang yung yung effect niya. So parang after few seconds lang, I felt a little dizzy, and then after that wala na akong naramdaman. So tulog na kagad. Then after that, gising ko, tapos na yung operation. So
Nag-underwent ako ng colonoscopy and endoscopy. So kailangan akong bigyan ng general anesthesia.
Based from sa experience ko, well, yun kasi dental. So, well, ang masabi ko lang naman sa experience ko is that first, it's syempre effective kasi I felt na gumana siya. And then, regarding other effects, wala naman.
In-injectionan ako before nung procedure ko. Tapos, after mga ilang minuto, yung nag-effect na yung anesthesia, inantok na ako, tapos parang naging manhid na yung pakiramdam ko. Tapos, nakatulog rin ako.
Nag-numb talaga yung kalahati ng katawan ko. Kumbaga parang naramdaman ko para akong manananggal na parang natanggalan ng kalahati ng katawan.
Naramdaman ko lang na tinurukan ako sa likod. Tapos nararamdaman mo yung anesthesia kasi medyo thick yung consistency niya. So parang ramdam mo kapag pumapasok na siya sa ugat mo. So yun, after nun parang ilang seconds lang ata, nakatulog na ako.
Ay, next thing na nangyari, nagising na lang ako, tapos na din yung procedure. Parang mabigat yung feeling, or parang mabigat yung katawan ko, parang nabugbog yung pakiramdam.
I think it's more of kailangan na ma-explain sa kanila ng maayos. And yun din siguro sa part ng healthcare worker, they need also to be patient din siguro doon sa mga pasyente or sa mga taong takot na magpa-anesthesia.
Okay, thank you so much, TVUP. It's surprising, Dr. Susie. Very, very young, pero marami nang have undergone general anesthesia. That was
Oo, so
surprising for me.
meron na silang mga indications for anesthesia. No? Very
Mm-mm.
interesting, very interesting.
So just a little bit of housekeeping for today. So all Stop COVID Deaths certificates po, no, we've already sent them out. Webinars 134 pababa po, no. Meron pa lang pong mangilan-ngilan for webinar 135 that we're still sending out. And those who have watched at least 50% of the webinar duration will be the ones who will be receiving the certificates of attendance. So if you feel you should have received pero hindi po kayo nakatanggap, please email us at stopcoviddeaths at up.edu.ph. For our webinar for today, we will be having a standard panel discussion format. After our speakers have presented, we will hear from our reactor followed by a Q&A session. But before that, we have a cute intro video for our fun quiz segment for today.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Ewan ko, nakakatawa pa rin, Raymond. Kahit ulit-ulit. Natatawa pa rin ako.
That's true, that's true. Ako rin eh. TVU, can we have our poll on Slido? There we go. Can we also have it on the Zoom, yung ating pong poll quiz? Ayan, marami rin natatawa dun sa ating fun quiz. Pero at least Okay, there we go. So today we have 3 questions for our fun quiz segment. For those who are joining us outside of the Zoom via Facebook or sa YouTube po, please open up your browsers and enter into your address bar po, no, slido.com, and when you are prompted, input po 6510096. That's 6510096 for you to be able to participate in our fun quiz. For our first question for today, what are the different types of anesthesia? Is it A, local anesthesia, B, monitored, C, regional, D, general, or E, lahat po ng ating nabanggit? We'd like to greet those who are joining us from the GISING School and colleges, those who are joining us from Bataan, from Cavite, from UP Los Baños, from the Health Information Management Division, formerly the Medical Records Division ng Philippine General Hospital. Maraming salamat po. Those who are watching us from Manila, from Jose Reyes Hospital, Deca Homes, Loma de Gato, Marilao, Bulacan. Maraming salamat po. From Davao, from Southern Philippines Medical Center, also in Davao, from the Philippine General Hospital in Anesthesiology Department. Thank you so much. Mga Cavite, from the FEU Critical Care Unit Cath Lab. May mga nanonood po sa atin. From Davao City, Tondo, Manila. From the Regional Office of Tuguegarao, Region 2, DepEd Central Office. Maraming salamat po. Those who are also joining us from Malolos, Bulacan, La Consolacion University po. Thank you so much. And Bataan and Rizal Medical Center. For our second question reads, what are the side effects of anesthesia? Is it A, nausea, B, vomiting, C, grogginess, or D, all of the above? I'm seeing here in the chat may mga nanonood po. Obviously from Rizal Medical Center, Amang Rodriguez, MMC, Marikina City, Division of Pain Medicine ng Department of Anesthesia ng PGH, but also internationally, meron po tayo all the way from Algeria. Meron po tayo, I think that's the first time that I've seen that we have a viewer from Algeria, also from Taiwan, and from the Middle East. Maraming salamat po sa ating mga avid viewers at tagapanood sa atin po na galing po sa Middle East at sa ibang bansa. For our last question in our fun quiz, in an infant undergoing surgery, the least anesthesia is best because, is it A, the infantile brain does not feel much pain, or B, anesthetics depress the immune system, or C, anesthetics suppress the central nervous system development, or D, wala po, none of the above, wala po sa nabanggit. So hopefully marami pa po ang sumagot. We're seeing a few more trickling in yung mga sumasagot po sa ating fun quiz as we move on to our webinar proper for today. Dr. Susie.
Hi, thank you very much, Raymond. And let's go to our presenters. I think you've been waiting for this. So I'd like to introduce our first speaker. He's Clinical Associate Professor and Consultant with the Department of Anesthesiology at subspecialty in neuroanesthesia. He's also Chief of the Division of Orthopedic Anesthesia at the Philippine General Hospital. Let's give a warm welcome to Dr. Antonio Alan or Lon MANGUBAT. Dr. Lon, welcome to the webinar.
Hi, thank you very much. Yeah, Dr. Susie, Dr. Ray, salamat. Yeah, thank you for inviting me.
Sige, go ahead. Lon,
Okay, sige. Okay, salamat. Okay, sige. I'm gonna share my screen. Okay. Okay, so good afternoon to everyone. Hope I'm clear. Salamat ulit sa pag-imbita sa akin for this webinar. Natawa ko dun sa Mini Susie and Radar. Yeah. So nakakatuwa talaga. Hope you're all having fun. So wherever you are in the world, again, welcome. No? So, and then thank you also to the person on the seat interview. Very, very telling, no? Because maraming questions, maraming experiences yung tao sa anesthesia. Hopefully, I can explain a bit. So I'm Dr. Lon MANGUBAT from Anesthesiology sa UPPGH. My title is magbilang hanggang 10, tulog na ba ako, diba? So usually we tell patients, okay, bilang ka hanggang 10, tapos matutulog na tayo, diba? And usually hindi nga umaabot ng 10, tulog na. I think sa PATS interview or PATS survey natin, ang bilis lang, konting update, tapos natulog na sila. So I'm going to go through yung objectives ko for this one, which is I'm going to tell you the different types of anesthesia, the stages. I'll compare yung general anesthesia to normal sleep. So I'll see kung bakit rested na rested ang feeling natin, no, after pinatulog tayo. And very important, risk and complications of anesthesia. This is what makes people scared, diba? This is why, oh, natatakot ako, mamamatay ba ako dyan, magigising ba ako? Hopefully, I can answer some of these questions. And yung Q&A natin sa panel na afterwards. So the types of anesthesia, I think nandun siya sa questions natin. 4 main types, diba? Yung local anesthesia, yun lang, linanumb lang yung certain part, okay, usually using an injection or topical anesthetic. So let's say you have a lidocaine cream, magpapa-derma kayo, di ba? May mga blackheads kayo, acne treatment, you just put lidocaine on your cheek, di ba? It will numb a bit and then pwede ka nang magpa-beauty, di ba? So that's local anesthesia for you. Regional anesthesia, or is usually you block a part of the body, yung lower half, yung sinabi dun sa interview, para akong manananggal, di ba? So half of the body, usually that's spinal or epidural anesthesia, or just a part, really, yung kamay lang, one half of the body, yung arm or leg, di ba? So we do that, okay, usually in combination with sedation, or yung technical term na yun sa sedation is monitored anesthesia care. So monitored anesthesia care means binabantayan ka lang ng anesthesiologist to see na wala kang complications, or you can give sedation until deep, moderate, light, or deep sedation. So that's the third kind of anesthesia. Usually yung pure sedation lang, these are first procedures that are not painful. And what is an example of this? I think also in the interview, nakita natin yun, yung EGD colonoscopy, not very painful, the procedure, but a bit may discomfort, diba? You don't want something sa bibig mo na gising ka, diba? So we put them to moderate or deep sedation, also called monitored anesthesia care, and then you'll be sleeping also like a baby. And general anesthesia is what we use the blanket term for all na totally asleep. Okay, so the fears I think of anesthesia are, sa general anesthesia, magigising ba ako and what are the complications? So we'll go through that. Okay, so usually ito yung nakikita natin sa mga telenovela, mga movies. Okay, we're gonna put you to sleep, you're gonna see the mask, and then ilalagay sa'yo, konting hinga lang, and then matutulog ka na. So actually, medyo false yan, no? medyo false advertising yan. We can use gas induction na you breathe something to put you to sleep, but that's very rarely done. Why is it so? Kasi mabaho yung anesthesia eh. Yung actual gas, sabi nila amoy ipis, di ba? So you don't want to smell ipis, yun yung last mo bago ka matulog, di ba? Ako nasanay na ako, I actually like the smell, and no, hindi ako addict at hindi ako mahilig sa ipis, pero nasanay lang, di ba? So we usually don't do this. Usually yung mga patients sa pinapatulog na ganito are pediatric patients na ang gulo-gulo-gulo, we cannot put an IV line and then hindi natin malalagay yung gamot sa loob. But usually we induce through the IV. Okay. So ito yung stages natin ng anesthesia. Induction, which is the patient na totally awake na hanggang matulog. Okay, so that is the induction, the start of anesthesia. The second phase is maintenance na we keep the patient asleep all the time na inooperahan siya. So maintenance, we just maintain anesthesia in a deep state of anesthesia until matapos yung surgery. Pag matapos ang surgery, we start to turn off the anesthesia, reverse what anesthesia we can reverse, and then that is called the emergence phase. So from the asleep back to the pre-operative na gising siya, that is emergence. Okay, so I'm gonna go through all of these three very quickly. So yung induction, so this is for general anesthesia. For spinal anesthesia, iba yon. But I'm talking, I think, for general anesthesia, okay. Ang ginagawa natin, first we give the patient oxygen, okay, and then we tell them to breathe deeply. We're gonna put you to sleep already. Ito yung sinabi dun sa interview, okay, binigyan ako ng konting anesthesia, okay, and then we give usually yung medicine through the IV. Ito yung pampatulog. Nakikita nyo dito yung propofol, that's what we usually use. It's a drug that is very, very powerful. Many people natakot dito because of the great Michael Jackson, di ba, na dito siya namatay sa propofol overdose. Okay, marami tayong masasabi tungkol that, but this is not the Michael Jackson propofol lecture, so I will not go into that. Having said that, if it is administered by a properly trained physician, it's very, very safe. Medyo mahap dito, so dun sa interview they said may konting hap. This is what we say, and usually this is when we tell the patient, okay, count to 10 or count backwards, 10, 9, 8. And usually, hindi siya umaabot ng 10. Matutulog na siya even before siya umabot ng 0. Okay. So yun yung ano. Some patient, they say, Doc, ang lakas ko, hindi ako tinatalaban ng anesthesia, ganyan. Pwede, okay. Sometimes kasi, we give the propofol slowly kasi nga mahapdi siya, di ba? So, minsan naka-0 na sila, 10, 9, 8, tapos 0, Doc, hindi pa ako tulog, ang lakas ko. Well, that's good, okay, good for you. Pero talagang makakatulog ka. So, sometimes it just takes longer. Some people, mataas yung metabolism. Some people, let's say chronic alcoholics, they need a bigger dose, but there's no anesthesiologist na hindi magpapatulog ng patient. So, marami ding video sa TikTok na I've seen, di ba, na parang yung linalabanan ko ang anesthesia, kayang-kaya, yung ganyan. So, we actually, in my mind, parang pwede, pero eventually, makakatulog ka rin. So, kung hindi ka pinatulog ng anesthesiologist mo, huwag mo na siyang kunin ulit. Okay, so yun yung ano natin. Okay, and of course, pagtulog na, we give paralysis. Okay, so we use some scary terms, paralysis being one of them. Paralysis means lang muscle relaxation, which means kasi, minsan kailangan na relax yung organ or yung stomach, di ba? Para ma-operahan ng surgeon. Let's say you're doing colorectal surgery, magtatanggal ka ng bituka, and the surgeon needs to expose the abdomen, di ba? Yung iba, yung abs, ang lupit, di ba? Nag-ab workout, six-pack, ang tigas-tigas ng abdominal muscles. We give paralysis or muscle relaxation to make it soft so that the surgeon can open up the abdomen and operate and take out yung mga bituka na gusto niyang tanggalin. So that's what paralysis is. So you might feel, paralyzed ba? Baka hindi na ako hindi na ako makagalaw. So these are just terms we use which are essential for surgery. So after induction, maintenance phase na. So tulog ka na and we're going to keep you asleep the whole time already. Okay, so maintenance phase, this is what I want to compare to sleep. Okay, so ito yun. Here you'll see mga EEG findings of on the right side, normal sleep, on the left side, anesthesia. And as you can see, phase 1, phase 2. Phase 1 and phase 2, these are the early stages of anesthesia. Usually sa phase 3 tayo nag-o-opera. So phase 3 is surgical anesthesia. Yung deep phase 2 to phase 3, that's where anesthesia is. If you see phase 1 and phase 2, very similar to REM and non-REM sleep. So this is when they say, parang natulog lang ako. And when they wake up, Dok, parang ang sarap ng tulog ko. 1 hour lang yung operasyon, di ba? Pero parang 8 hours akong natulog. Precisely because anesthesia is similar to sleep in the lower or earlier phases of anesthesia. Pero ito na yung medyo nakakatakot ng konti, okay? And I'll tell you, so if you all get scared from anesthesia, listening to me, I'm just telling the truth, okay? So, ayun, and hopefully we'll answer your questions in terms of explaining it, diba? So, phase 3 and phase 4, actually, which is phase 3, as I said, that's usually where the phase or level where the surgeon operates on, okay? You see, you already have burst suppression or coma, okay? And in phase 4, we never go here to phase 4. But in some cases, let's say you have a very severe head injury where you need the brain to be very quiet, no activity at all, so that it can rest and recover. We can sometimes put patients in a coma or brain death like situation, okay? But in phase 3, actually, these are comatose states already. So, we don't say it kasi matatakot lahat ng patients. If you tell, let's say, magpapa-opera ka and then you've talked to your anesthesiologist, Dok, papatulugin mo ba ako? We don't say, coma, di ba? Wala nang magpapa-opera, di ba? So, wala nang surgery ever. So, we just say, papatulugin ka, gigisingin ka. But in actuality, ang nangyayari, we put you in a state of coma, okay? And why didn't you say coma, di ba? Bakit coma? Because what are the signs and symptoms na nasa coma ka? You're unconscious, no response to painful stimulus. So kahit anong gawin, hindi ka mag-respond. You do not breathe. So we help you breathe with a ventilator. You need cardiorespiratory support. Okay. You need thermoregulatory support, which means nagiging hypothermic ka rin. You lose your body heat, diba? You get very cold. And brainstem reflexes are absent. So hindi ka uubo, you do not gag, hindi ka luluha, corneal reflex, eyelash reflex, nothing at all. So this is actually a comatose state. And all patients under deep anesthesia are in this state, diba? So, Doc, delikado yan, diba? This is a coma, diba? But what I want to say, and this is already in the next part, okay, which is yung emergence. And the emergence is the coma that we give in anesthesia or the very deep sleep we give in anesthesia, which is like a coma, okay, is reversible and controllable. Yun yung difference ng coma sa brain death and anesthesia from coma. Okay, so it is reversible. That is what I want to say. So from a patient who is asleep to a patient who is waking up, this is what we call emergence. Okay, so what happens here? Usually we turn off yung gas, the thing that puts you to sleep. Okay, and then after that, pag na-off na natin yun, passively mawawala yung anesthesia sa system. There are some medications, yung mga binigay nating muscle relaxant, paralysis, pwede nating i-reverse yun. So we give reversal for that. Let's say we give morphine or fentanyl, very, very powerful opioids for the pain. We can also reverse that. And then yung gas natin, walang reversal yun, passive process kasi very fast-acting yung drugs. In mga 5 to 15 minutes, halos wala na yan sa system. And the patient will wake up already. So the signs of the patient waking up, so I want to say again, reversible and controlled siya. So nare-reverse, okay? And that is what we want to tell as anesthesiologists, okay? Yes, we put you deep to sleep. And yes, we are guarding you the whole time. And yes, we can reverse it and wake you up, okay? That is our promise as anesthesiologists, diba? If not, diba, then what for, diba? Anyone can put anyone to sleep. Dapat magising yung patient. So what are the signs na nare-reverse or nagigising na yung patient? Yung apnea or the fact that they're not breathing, soon magiging regular breathing na. And then lalabas na or babalik yung reflexes natin. Salivation, maglalaway na gag reflex, grimacing, corneal reflex, eyelash reflex, and then after that, magigising na yung patient. So that is when you bring the patient to the recovery room because it takes some time for everything to wear off totally. So usually mga 1 hour to 2 hours, 30 minutes to 2 hours, ganyan, until you're fully recovered. So we bring you to the recovery room so you can rest and recover from anesthesia. So those are the things. So the whole time, we are monitoring your vital signs, okay? You might ask, Doc, baka too deep? Ba ayaw ko coma di ba? How do you know na coma na, okay? And then, why don't we just be phase 2? Okay, so that is the nature of anesthesia talaga. Since the 1800s, anesthesia has been invented mid-1800s, so more than 150 years ng anesthesia. And really, when you say general anesthesia, that's how it is, okay? We monitor you by really complete monitoring the whole time. And we don't leave. So contrary sa mga sinasabi mo na pinatulog lang tapos nagkakape na kami, nagbabasa ng diaryo, old school, no? Diaryo, okay? So nagbabasa ng iPad, whatever. No, we're actually looking at you the whole time. We have monitors. We can monitor how deep you are. Medyo mahal lang yun. I'll discuss that later. Okay. So ito na yung risks or complications of anesthesia. Minor, nung nasa gitna, sore throat, kasi we put a tube to your throat, diba? So, sore throat, mawawala din yan after a few days, a few hours, diba? Just drink lots of water. Chills and shivering because we get hypothermic. We lose our body temperature. Headache, yung grogginess, yeah. So that's all part of it. Diba? Your head feels very heavy. And I think when a person in the seat interview, that was the main complaint. Parang mabigat yung ulo, mabigat yung katawan, muscle pain. Okay? Because of the drugs we give, sometimes yung position ng patient, na especially kung nakaside, nakadapa yung patient for the procedure, you can have muscle pain, okay? And then nausea and vomiting. This is one of the worst, no? Na parang nagsusuka. We give you lots of medicines, no, to try to prevent nausea and vomiting. Yung risk factor ng nausea and vomiting, young, female, and non-smoker. So yung advice ko sa mga tao, kung mag-yosi kayo, magde-decrease yung, yung incidence of nausea and vomiting. I'm not telling to smoke, I'm just saying, yung isang benefit ng smoking is when you're given anesthesia, less yung incidence of nausea and vomiting. Delirium usually in older patients, yung nagwawala after anesthesia. But afterwards, hindi ko makontrol sarili ko, parang nagwawala, sabi nila, parang gusto kong bumangon. Sometimes that happens. May risk factors there, and we can give medicines to try to prevent delirium. Yung pinaka nakakatakot, yung lower right na to, which is awareness, diba? Na parang under anesthesia, you're awake and you feel everything. Pwede mo ikwento yung usapan ng surgeon and then like that, but you cannot move. And that happens, it's very rare, okay, but it sometimes happens. How does this happen? Many factors, not really. Pwedeng patient factor, pwedeng, as I said, yung una, fast metabolizer, he needs more anesthesia, diba? The other one is equipment failure. Sometimes it's not working pala, you're not giving the proper amount of drug. So these are the things that can happen, diba? And then so it's a very bad complication, and that's what I think people are very scared of. Yung moving nga, diba? Yung awake, I think 20 something, diba? That the patient was awake and then there, okay? And this is something that we're very conscious about as anesthesiologists. Ayaw namin na mangyari to because really it's a bad, very bad experience and very traumatic for the patient. So how do we make sure na wala awareness? So usually we use surrogate markers. Yung blood pressure natin, heart rate, hindi siya 100% accurate. But usually, let's say mababa yung blood pressure and then the heart rate, you're not tachycardic, your heart rate is not fast. That means you're not feeling any pain and you're asleep, especially, let's say they're operating na on your heart, on your stomach, and then ganyan. And then usually, if the blood pressure, vital signs are okay, and then there will be no awareness. We have specific monitors. We call it what's this? Dept of Anesthesia monitor. And those are actually EEGs na linalagay natin. And then that one, we can really, since may EEG siya, we can tell how deep the patient is talaga. The only drawback to this is quite expensive yun. And usually when you use it, mga 10,000 pesos. So let's say you're doing breast mass excision under local anesthesia, IV sedation. You don't want to remember anything. Pero yung magiging total cost mo of the entire procedure, 15,000 pesos, di ba? Will you add 10,000 pesos pa additional so that you're sure na walang awareness? Pwede din. It's a risk-benefit analysis that you can do. Diba? That, yeah, we can put monitors in all our patients. But usually, trust that we are monitoring you and that we know how deep you are because of our training, because of how we look at your vital signs, and like that. But yet, if you want a Dept of Anesthesia monitors, pwede din yun, di ba? But not all institutions will have it also, not all hospitals will have it, and the cost is also prohibitive. In my practice, awareness very, 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 very rare. And if you look at the literature, talagang talagang rare siya. So talk with your anesthesiologist, discuss the plan, and then discuss yung risks and complications with it. Okay. So hopefully this very, very short overview makes you understand a bit about what we do as anesthesiologists, its relation to sleep, okay? And then also yung natin, yung how we put you to sleep and how we wake you up. So yung take-home message ko is actually summary, hindi siya take-home message, it's a recommendation, di ba? Para maganda buhay natin or para safe tayo, get a good anesthesiologist. I'm not saying ako yun, pero get a good anesthesiologist so that you can talk to them, get someone you're comfortable with, that your surgeon is comfortable with, so that you're safe. I see a few questions already, there's a Q&A, but we'll answer that later on. So thank you very much for listening to me.
Okay, thank you very much. That's Dr. Lon Manggubat. Ang ganda ng presentation niya, napakadaling maintindihan. So thank you so much. You can see all the emoticons, may mga clapping, may mga heart, and I'm sure our audience has really appreciated your explanation. Okay, Raymond, please introduce our next speaker.
Thank you, Dr. Susie. Thank you also, Dr. Mangubat, who's the Chief of the Division of Orthopedic Anesthesia po sa Philippine General Hospital, for our second speaker. But before I introduce her, just to remind everyone, please start putting in your questions po para sa ating Q&A session. We'll be choosing from the upvoted questions po. We encourage everyone to start typing in your questions in the Zoom Q&A box or in the comment section of Stop COVID Deaths or TVUP Facebook pages or TVUP YouTube channel. Okay, for our next presenter, retired clinical faculty, also consultant with the Department of Anesthesiology. Her subspecialty is in pediatric anesthesia. Please welcome to your screen the past chair of the Department of Anesthesiology at the Philippine General Hospital, Dr. ILUMINADA CAMAGAY, Dr. Boots CAMAGAY. Ma'am.
Afternoon, I'm CAMAGAY, an anesthesiologist with an interest both in neuroanesthesia and pediatric anesthesia. Over the years, I have had to translate the details of the anesthetic science for the layperson. Hopefully, somehow, the fears could be assuaged, especially in the young patients and their caregivers. A very common concern is, makakayanan ba ng maliit na bata ang anesthesia? Or baka hindi gumising? Baka sumobra ang anesthesia? So prior to the mid-1980s, it was assumed that infants did not perceive pain due to the relative immaturity of the developing central nervous system. The use of volatile inhalation general anesthetics, as was taken up by Dr. Lon, was limited because of their cardiac depressant effects and the inability to precisely monitor the hemodynamic and respiratory parameters of very young infants. At that time, there were no pediatric appropriate oximeters, capnographs, and small-sized blood pressure cuffs for non-invasive blood pressure measurements. So I will just share with you some of my slides at this time. Okay. Babalik ako. All right. At that time, before the mid-1980s, neonatal anesthesia was managed with a minimal anesthetic approach, which they call the Liverpool technique. So here we have a depiction of Liverpool. Liverpool is otherwise known as the place where the Beatles started their careers, Liverpool. But Liverpool is also known for being the home of anesthesia, the Liverpool technique, where they used only nitrous oxide, which doesn't put people to sleep, and muscle relaxant. So the babies weren't asleep. It is also the home of Professor or Dr. Gordon Jackson Rees, which is the Alder Hey Children's Hospital in Liverpool. And Dr. Jackson Rees originated the Jackson Rees technique, the Jackson Rees TPs, Jackson Rees circuit, and Jackson Rees pediatric anesthesia. So at this time, many studies were undertaken to find out if we could use anesthesia on premature and full-term newborn patients. And they found out that premature and full-term patients can mount a substantial stress response to surgery and anesthesia under the Liverpool technique, which means to say that under this technique, there was maximum epinephrine and norepinephrine secreted and increased insulin and glucagon secreted as a hormonal response. Then later on, it was found out that in patients or neonates who underwent open heart surgery, when fentanyl was added to this nitrous oxide and the muscle relaxant, there was almost no mortality to those patients who underwent heart surgery compared to those on whom minimal anesthetic or the Liverpool technique was used. There was almost 100% mortality. So the bottom line is that anesthesia was good for infants undergoing surgery. Now, later on, several studies were being undertaken to find out if effects of early painful stimulation may give rise to permanent changes in pain processing and impaired development, including altered pain sensitivity and maladaptive behavior later in life of these children. Today, providing anesthesia and preventing pain and stress responses in the youngest of patients is considered a standard of anesthesia care. Withholding anesthetics during painful procedures in infants is considered unethical. All right? Now, the possibility of anesthetic neurotoxicity, including neuroapoptosis or cell death in the brain in the neonate, young infant, and fetus is the most pressing question facing the field of pediatric and fetal anesthesia today. There is a growing population of children who receive anesthesia. And in the US, these figures are about 2016, approximately 6 million children annually, 2 to 3 million are less than 36 months of age. Approximately 1.5 million are less than 12 months of age. And at this time, there are approximately 1,500 fetal interventions and surgeries. In fact, in PGH, we have had some fetuses undergoing surgery while still in the mother's womb. So, of particular concern would be longer procedures where the mother receives general anesthesia with significant concentrations of volatile anesthesia in order to maintain a quiet uterus that would enable fetal surgery to be performed. So the anesthetics are received both by the mother and the fetus during fetal surgery. Now, there are concerns about this because of the significant growth of the fetus and the effects of the sedation and analgesia to this rapidly growing fetus. So there are concerns also that the very rapid development of the fetal brain makes this patient group most vulnerable to neurotoxicity from anesthesia. Another concern is that fetuses undergoing surgical procedures will often have repeated anesthetics in postnatal life. Example are those fetuses with diaphragmatic hernia or fetuses with who will have myelomeningocele. All right. Now, what are these agents? This table shows you the anesthetic, sedative, and analgesic agents that are often used. We have halogenated agents such as sevoflurane, isoflurane, desflurane, nitrous oxide. By the way, nitrous oxide does not result in sedation or sleep. Benzodiazepines, propofol, as Dr. Lon has showed, barbiturates, etomidate, chloral hydrate, ketamine, opioids, and dexmedetomidine. Binding and interaction of these agents with GABA and NMDA receptors could have effects on brain death or neuroapoptosis and the formation of synapses or synaptogenesis in the rapidly developing immature brain. The proposed mechanism, okay, look here, the halogenated anesthetics, benzodiazepines, propofol, barbiturates, etomidate, and chloral hydrate bind to the GABA receptors. Ketamine binds to the NMDA receptors, opioids to the mu receptors. Okay. And this shows the proposed mechanism for anesthesia-induced brain death in the developing brain. So there is a binding followed by eventually the mitochondrial disruption resulting in the release of capsase 9 from the mitochondria and inciting the completion of the neuroapoptosis or brain death process. There are also other mechanisms which include decreased dendrite and spine formation and decreased neuronal migration. Now, studies have been made, no? Initially, there were retrospective studies. Wilder et al. In 2009 published the first large-scale retrospective study of anesthetic exposure under 4 years of age. He assessed the incidence of later behavioral, learning, or developmental problems at school age. They found that with prolonged or repeated exposure to anesthesia, there was an approximately twofold increase in the rate of identifications of these problems compared to subjects with no anesthetic exposure. Since that time, a number of retrospective studies have been published with mixed results as to the association of anesthetic exposure with later neurobehavioral and developing problems. The problem with retrospective studies is we cannot plan them. No? So we are better off with prospective studies, and we have 2 prospective studies that have been undertaken in 2016. First is the GAS, or General Anesthesia versus Spinal Anesthesia study, undertaken in 2016. And this is a landmark study because it is the first fully prospective randomized controlled trial of anesthetic technique and neurodevelopment outcome. They enrolled 722 infants less than 6 weeks post-conceptual age undergoing hernia repair in 28 centers in North America, Europe, Australia, and New England. And they were randomized to receive general anesthesia with sevoflurane versus spinal anesthesia with bupivacaine. No? So the first outcome of the study was full-scale taking IQ with a difference of 5 points. And the mean anesthetic time was 54 minutes. So at the time that this paper was made, they were still with the first phase. So they found out in the first phase that both groups were identical overall as to baseline clinical and demographic characteristics. That's good to know as far as the effects of a well-managed anesthetic is concerned. We're still going to look forward to the 5 years after study. Then the other study is the PANDA study, which is the Pediatric Anesthesia Neurodevelopment Assessment, which was also undertaken in 2016. They enrolled 105 siblings. One sibling has anesthesia in the past at age 3 years or younger for hernia repair. The other sibling was not exposed to anesthesia and was within 3 years in age to the exposed sibling. Mean anesthesia duration was 80 minutes with a range of 20 to 249 minutes. This is an innovative study. It minimized genetic and socioeconomic differences between groups. And the scores between groups in these outcomes were virtually identical. Therefore, the implication here is that a single, relatively brief exposure is not associated with an increased incidence of neurobehavioral adverse effects. And to help us decide, the US FDA Drug Safety Communication of 2016 said that repeated or lengthy use of general anesthesia and sedation drugs during surgeries of children younger than 3 years or in pregnant women during their third trimester may affect the development of children's brains. So for all of us, let us be careful. And lengthy is defined as greater than 3 hours. Right, and with that presentation, I would like to thank the hosts of this webinar for allowing me to share them with you. Thank you.
Thank you very much for the excellent presentation from Dr. Boots Camagay and the history. And this is really a presentation on updates, no, on new things that are happening in terms of anesthesia for very, very young patients. So maraming salamat po. Thank you. Okay, Raymond, over to you or ako ba? Teka. Raymond, are you there? Uy, nawala si Raymond ah. Okay, anyway, we'll have Dr. Boots with us on the Q&A after this. And now I am very pleased to welcome back to the webinar someone who has been with us in the first season back in 2020 when we talked about anesthesiology and had very positive feedback about that session. Today, she will be a reactor to the two presentations. Please welcome Professor and Chair of the Department of Anesthesiology at the UP Philippine General Hospital with a subspecialty in cardiothoracic and vascular anesthesia, Dr. Grace Ann HERBOSA. Welcome, Grace.
Hello again. So magandang hapon po sa inyong lahat. Hello, Susie and Raymond. So I'm going to react to or add or reiterate some of the points that Lon and Dr. Boots Camagay has talked about. And I'd like to start by saying that anesthetics really transformed surgical medicine. So it's actually anesthesia that makes surgery happen. And from the first administration of anesthesia more than 177 years ago, it all started with ether. So, and to this date, we use sevoflurane, isoflurane, which are all types of modern ether. So basically, what we have then and today is just an improved version 177 years ago. Now, the first lecture talked about sleep and anesthesia. Now, as anesthesiologists, and we our first step is, of course, is to meet the patient preoperatively and get their consent. Now, this consent should be valued by the anesthesiologist. You know why? Because if a patient gives consent for anesthesia, it's practically putting their trust on us as anesthesiologists, because practically, as we put them into a depth of anesthesia or unconsciousness, we actually control all their physiologic systems. We breathe for them. We control their blood pressure and all. So the respect for consent and the way we get that consent and allow the patient to understand what we are, I think we should give a lot of importance to this. Now, sleep and anesthesia. Colloquially, the lay person would just say, patulugin niyo ako, doc, di ba? I'd like to show you that sleep is very much different from anesthesia. In the real sense, anesthesia is really a reversible drug-induced coma, as Lon has alluded to. But of course, we don't want to scare our patients. Now, and this has been seen in experiments done during sleep. No, when you have patients and you put them under anesthesia and put an EEG, you can see that the oscillations are different. In normal sleep, pag natulog tayo, we have what we call non-REM and REM sleep. And these are two different stages of sleep. Non-REM is when heart rate and blood pressures are high, and the oscillations are shorter amplitude, longer frequencies. And then we can vacillate during sleep between non-REM to REM sleep with 90-minute intervals. And so at night, this happens about 4 to 6 times at night. During anesthesia, it's different. The amplitude of the brain waves are higher, frequency shorter. And from chaos, it becomes more organized. So it's really different. I'm saying this because I know that everybody knows about the thing that happened with Michael Jackson with the propofol, and he wanted sleep. That's why he used this every day, every night. Now, what he didn't know is the sleep produced by propofol is not regular sleep. He actually was getting sleep deprived because it's the total opposite of regular sleep, although he did have a feeling of well-being. Okay, so some authors would say that because of the repeated propofol each night, it caused neurobehavioral changes with him, and probably he became like an addict to propofol sleep. No, so we know how it ended. Okay, so the suggestion really is, instead of using the metaphor of sleep in explaining it to our patients, is really to say that they will undergo stage, they will go through unconsciousness, and then we're there beside them to monitor them and take care of them as anesthesiologists, rather than just saying, just you're going to sleep and that's about it. Okay. So next is the developing brain with Dr. CAMAGAY. Again, with the oscillations in the brain. Now, there is a nice study from Boston Children's Hospital, and they monitored babies from 0 to 6 months of age. What's it? Yeah, to 6 months, and they put EEGs on them. And what did they find as they underwent anesthesia? The oscillations of the babies were strongest and have the highest amplitude for the broadest frequency band when younger. And as you age, this frequency band tends to drop and seems to look like frequency bands of adults. Okay. From 0 to 3 months, they noticed that these babies only had slow oscillations. And at 3 months, something magical happens, and they see that it slowly changes to the adult forms. Therefore, the degree of inhibition is changing, and this is a sign of brain development. So this is a nice study because, as Dr. CAMAGAY has said, we shouldn't take our babies for granted just because they're babies and we think that anesthesia might be bad for them is to make sure that we give the right anesthetic for the right surgical procedure. So there are really many studies about consciousness and anesthesia. And in fact, as we look at the stages of consciousness, it ranges from the awake state, the asleep state, the comatose state, even the meditation state. So there is a resurgence of, as I said, studies in the brain for consciousness, and as being advocated now by the first world countries, is not just to monitor now pulse oximetry and oxygenation, is they're advocating that we now monitor the brain as well, because that's the thing that we should, I think that the outcome that we want, that the patient post-operatively will wake up in his pre-anesthetic state or even improved. Thank you.
Okay, thank you very much, Grace. Ganda rin yung reaction niya, no? I think, tama nga, parang we say natutulog, pinapatulog, pero actually, I think what our doctors are saying is it's really much more than going to sleep. And we will have time to discuss questions from the audience and hear the answers from our experts. So thank you so much, Grace. You'll see all the clapping and the hearts coming out there in appreciation of your reaction. Okay, Raymond, over to you.
Thank you, Dr. Herbosa, Dr. Susie. Thank you so much. We'd like to ask at this point our panel to switch on your videos so we can begin our Q&A session. But before we proceed, I will take a very quick break lang po for our special public service announcement for today.
Aloy, bilisan mo! Dali! Wala!
Ha? Ano nangyari? Ba't hindi kita makapitan?
Handa ka na ba, Kaloy?
Oo naman, ate. Nabakunahan na kami. May powers na kami laban sa inyo.
At hindi nyo na kami basta-bastang makakapitan. Yehey!
Sisiw!
Kaya mga bata, magpapakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you so much, TVUP, the COVID Communication Public Service Announcements, one of the many creative outputs of the webinar team to push for pediatric vaccination for children age 5 and above. Please share this clip within all your social media accounts. Stay safe and stay well. Magpasama na po sa Bakuna Center. Let's start with our questions, Dr. Susie.
Yeah, I have a provocative question to start this discussion since we have three very outstanding anesthesiologists with us. And I'm going to pick up from Lon's last slide. Sabi niya, choose a good anesthesiologist. No? So, what is a good anesthesiologist? How do we find that? Sige, we'll start with Lon. Ikaw nagpasimula nito eh. Sige, Lon.
That's very, thank you, Susie. Very provocative na. No? I'd like to say na everyone in our department is good, no? So, yun lang, no? Yun yung ko. Basta galing sa Department of Anesthesiology, UPPJ, that's good. But having said that, we have certification, no? So, may board certification tayo. And our members, si Dr. CAMAGAY, Dr. HERBOSA, Grace and Boots have been part of the Philippine Board of Anesthesiology and may certification tayo. So, hopefully, if the certification process is good, then any board-certified anesthesiologist would classify or as a good anesthesiologist, no? Yeah. So, yun yung answer ko. Yeah.
Okay, Boots, would you like to comment on that?
Yes. Good. They should come from a training program that is certified by the Philippine Board of Anesthesiology, because the requirements of the board are very stringent. I second the motion.
Yeah. Oh, Grace, for kasi you're chair of the department, no? how do you train the anesthesiologists of PGH to become good? Ano ang dinadaanan nila?
Oh, that's really complicated. Well, the department really has a structured program. Now, we're one of I think one of the programs that can do this because of the number of patients that we do, meaning because we have enough patients, we do it, we call it the modular type. So the residents rotate for a certain number of weeks in a certain division. So that being said, so they're relatively focused. So aside from that, of course, we have to do assessments. It's important to do assessments of all our trainees. We do weekly short quiz exams. We have oral exams, the usual things we give our residents. We also give them a chance to do their own self-directed learning, because these are all adults. Residents, they're all professionals, they're all doctors, they're not students really. So we give them a chance to grow on their own. We also would like to encourage them to become leaders, to be able to communicate well, be disciplined in answering and documenting all their procedures. That's all part of growing up in anesthesia. And as part of the board, we believe that when we're a skills-based specialty, so we have numbers that we have to fulfill. No, we have numbers for procedures, numbers for cases, so it's pretty much structured. So hopefully, with all this skeleton framework, at the end we come up with anesthesiologists who have been exposed to almost all the horrific scenarios, because what's important is not just the skill, but being immersed in a clinical scenario where you can see successes as well as failures, near misses, and learn from them. So each day should really be a blessing as well as lessons learned. If you fail, then you just move on and learn again. It's a very ang anesthesia department ngayon, it's not what do you call this? It's a very friendly one for education. I think that's what this generation needs. It's not like before, it's very strict, diba? And maybe now I think it's more engaging. Aside from that, we'd also like to inculcate values of loyalty, respect, and efficiency, maybe, among our residents. So yun lang. If among the anesthesia training programs we're listening, each program will have its own specific way it handles the curriculum. And hopefully, as Lon said, at the very end, when you pass all your examinations, we come up with good anesthesiologists, meaning ethically practicing anesthesiologists that will perform well as a member of a team, because we don't work alone in anesthesia. We do personalized medicine and we're part of a team. So that's the surgeon, the nurses, the institutional worker. Thanks.
Thank you very much, Grace. Raymond, I think we've got a number of questions.
Dr. Boots has something to add, Dr. Susie.
Yeah. Sige. Oh, go ahead. Boots, go ahead.
I'm trying to relate this session with COVID.
Go ahead.
Yes, the COVID session, the COVID pandemic has resulted in a diminished number of clinical exposures of all trainees in anesthesia. So, but it has a positive side. It has enabled us to respond to COVID-associated disorders as a new branch of anesthesia. So in the PGH, for instance, we have this additional COVID-inspired or COVID aspect of anesthesia training. The negative side is there are many training institutions who have had diminished admissions of what used to be routine cases for anesthesia before. So with this in mind, I think we just have to try to be patient in those institutions which have had diminished admissions to try to recover. And the Philippine Board of Anesthesiology is aware of this downside. And so in order to be able to maintain the stringent requirements that should make a good anesthesiologist, then we will have to, in the meantime, in this interim period, we have taken down or decreased the required cases that will enable anesthesiologists to apply for their accreditation. This is just interim. Hopefully, by the time that we are back on track, we will restore the necessary number of cases and the nature of the cases that will be needed for certification as a good anesthesiologist. That's all. Thank you.
Yeah, thank you very much, Boots. No? Was there
Additional from
any-
from Dr. Ted Herbosa.
Oh, Ted, welcome to the webinar.
Sir Ted?
Nakamute siya.
I think he's still... Nakamute ka, sir. Nakamute ka, sir.
I just like to support my wife, no? Grace.
Thank you.
No, but seriously, as a surgeon and as a trauma surgeon, we have many patients and many people, even other specialties, have actually underrated the field of anesthesia. And that's because they don't know the acute medicine that they actually practice. So I'm a surgeon. I'm dependent on making sure that the patient under the knife is able to be alive and wake up after. So that's a very critical. To us surgeons, we hear the praises. Post-op, sasabihin nung surgeon sa amin, nung patient sa amin, Doc, ang galing niyo mag-opera, wala akong naramdaman. Pero actually, that is not a tribute to me. That is a tribute to the anesthesiologist that put the patient to sleep and made them wake up. So I'm really happy TVUP has put up this episode because our anesthesiologist is number one, we lack anesthesiologists in the Philippines to implement universal healthcare. We produce too many surgeons, yet we don't have enough competent, good anesthesiologists. And you know what can happen if the anesthesiologists are not competent, you get into a crisis or you can even die from the procedure. So it's very important that we understand what our colleagues in anesthesia do and that they are part of the health team. They are a very important part in the whole health team that provides surgical care. And today, not even surgical care, also diagnostic procedures like endoscopy and biopsies and everything, all other things done by different specialties. What they call it, Grace, procedures done outside OR?
Non-operating room anesthesia.
Yeah, the non-operating room anesthesia, which has actually increased in proportion to the total number of anesthesia. So yun lang, para makita yung perspective from the public health and the hospital health system and the medical health teams, the anesthesiologists have long been underrated. I'm glad TBUP has found a way to introduce the specialty to everyone. Thank you. Okay ba, Grace?
May kasalanan to si Ted kaya okay. Yeah. So thank you so much for that, Ted. I think that's an important point, no, na typically, because you see your surgeon and your surgeon talks to you a lot and all, but actually, considering how our experts have described what they do, which is they put you in a reversible coma. They are really holding your life. They're the ones who are holding your life, no, in their hands while you're going through the surgery. I've got a question here from someone who sent me a text message. And before we go into the questions, because Raymond, I think we have a couple of questions.
Yeah, yes.
So the question is, why do we not remember? Why do we lose our memory when we are under anesthesia? Yun. Why do we lose our memory of being under anesthesia? Yun. Anyone wants to answer? How come we don't remember it?
Can I?
Go ahead.
Yes,
Go
Dr.
ahead.
Camagay, go ahead, ma'am.
I think I took that up, no, because these anesthetic agents, actually, not just the anesthetic agents, specifically those which have to do with benzodiazepines, the amnesic agents. Okay, they bind to the GABA receptors, and then after binding, movement through the synapses is stopped. So whatever stimulus you receive through your senses does not get transmitted. So there is no transmission. And therefore, if there is no imprinting in the brain, you have no memory.
Yeah. Thank you. Thank you for that, Boots. I think ano yan, no? Parang there was another question here. This is interesting. If you drink a lot of alcohol, okay, does that mean you need more anesthesia when you're operated on? This is a common notion. Na may mga hindi madaling talaban ng anesthesia. Okay.
Okay, I'd like to answer that since I think I discussed it a bit, no. So there's two things, no, acute alcohol and chronic alcohol, no. So kung acute alcohol, let's say lasing ka, di ba? Na you just drank a few, you'll actually need less anesthesia because the alcohol itself makes you sleepy. Now for chronic alcoholics, yung talagang everyday umiinom sila, as in lasengo talaga, no. All their enzymes are actually no, they're all expressed already, and their metabolism for these kinds of agents are faster. So these kinds of patients, so chronic alcoholics, mas matagal or mas hindi tinatalaban, to put it in layman's terms, yung diba? Pero yung lasing na nakita mo na aksidente and then motorcycle accident kasi nakainom, diba? Then we're putting them to sleep. Sometimes you just give them midazolam and then they're asleep already because they're practically asleep na nga, diba? Pero yung chronic alcoholic, yes. So to answer your question, it depends, no? Yeah, in terms of what kind of alcohol and yung alcohol consumption habits mo.
Thank you so much, Lon. Raymond, let's go to our questions from the audience.
A question from the audience. I'll post this to the chair, Dr. Grace HERBOSA, from Dr. Joseph Tortona. Since there is no way of testing the patient for allergy to general anesthesia, what is their accountability? Should the patient die from anaphylactic reaction to the general anesthetic?
Okay. If you really have a history of allergies, of a lot of allergies, we also test for it. You know, we refer them, of course, to the allergy specialists, and they do tests for local anesthetics, the benzodiazepines, the common one, opioids. However, most of the time, we just ask the question, may allergy ka ba? Okay. And then if, let's say, they're allergic to egg, then we ask, what's the manifestation? Is it rash? Is it difficulty breathing? So that way we have a more or less an idea of how sensitive the patient is. No, so but if it happens, let's say, because we can't catch everything, no, but under general anesthesia, one, it's very hard to identify an allergy or an anaphylaxis because you're under general anesthesia. So the most common is they will still have rashes, wheals. So that's the first. And then you can have hypotension, intractable hypotension, which is unresponsive to fluids or to the regular vasopressors that we use. And then we do know the most common causes for an anaphylaxis under anesthesia. Now, we have some medications which are known to do this. So if we have a high suspicion that it can be anaphylaxis, we then probably start epinephrine. Now, regarding liabilities, I'm not a I'm not an expert in that, but this should be just the fact that we ask questions on allergies and we are able to get the consent of the patient. I guess it has to be part of the education of the patient as they sign the consent. I have yet to see a legal battle on anaphylaxis because when it happens, it's very hard to prove as well. You know, you have to do tryptase exam, and there's a certain hour that, you know, that has to be, I mean, the blood has to be extracted within a certain hour. So I don't know, what's the experience of Dr. Camagay and Lon? And besides, if it's an anaphylaxis, we do standard acute care for that. No, so it's resuscitation, and hopefully the patient survives. Any comments? Yes, Dr. Camagay.
When we talk of general inhalation agents, anesthetic agents, there is less likely anaphylactic reactions to them because they gain entry to the body through the lungs by breathing in. And then they are carried by the blood to the brain. And it's very easy to terminate their action. They don't stay there by decreasing their concentration or waking them up. So it's less likely. What we encounter more problems with drugs that are given intravenous. They're carried by the blood and they have receptors that could interact with the agent and produce the anaphylactic reaction. So I have experience with inhalation anesthetics as working with Dr. Claver Ramos. Our experience is if we suspect, with a patient who has a high history of allergy or anaphylactics, we correlate if this concentration of inhaled anesthetic brings down the blood pressure too much, hypotension, all things considered, then we suspect that this patient is allergic to this agent. Because normally, let's say if you're giving the patient 1% of an inhalation anesthetic like sevoflurane, then the blood pressure tends to be normal for that level. But if it really goes down and the patient is well hydrated, then you suspect, because then you have deprived this patient of the adrenaline stores that he has because he has reacted to the agent. So, I mean, that is clinically what we have been doing over the years. So this could be helpful to others who may try to detect an anaphylactic or an allergic reaction in patients who are undergoing inhalation general anesthesia.
I have a comment. Yeah.
Yeah, go ahead, Don. Go
Very
ahead.
quickly. Actually, I'd like to tackle this not from the clinician's point of view, from the patient's point of view. Actually, I like the question of si Mr. Joseph very much, Yeah. Kasi, alam mo, why they ask these questions, it's not because, kasi we look at very technically, because usually when something happens under anesthesia, what do people tell the patients? They tell them, and these are laymen, and I'm sure marami dito sa 397 are not anesthesiologists, are not surgeons. They say, ay, namatay siya. Bakit? Nagka-allergy sa anesthesia di ba? That's usually what people get. And there is a misconception because I think in terms of how it is told to the patient or how it is packaged, that's how the morbidity or mortality comes out. Na sinasabi ng whoever, di ba? You talk to your neighbor, oh, namatay kasi may allergy sa anesthesia. But true anesthetic allergies, as mentioned by Grace and Boots, very, very, very rare. We test it, we're very liability. Usually you die from other causes, but Especially old school, yung mga surgeons natin. I'm not blaming the surgeons of the HERBOSA, Dion, di ba, ganyan. Pero sinasabi, hindi niya nakayanan eh. Ang hina, di ba? Ang lakas ng anesthesia, nagka-allergy siya. And that is why we're here, di ba? We're here to explain and to try to know that anesthesia is very safe. Coma siya will wake you up. If you get an allergy, which is very, 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 very rare, we can handle it. So I think mislabeled lang talaga tayo in terms of allergy. So thank you very much, Joseph, for helping us to maybe clarify that a bit. So true anesthetic allergy to our agents, Deferring, Chibubrain, even Midazolam, so low the incidence. Talagang what Grace was talking about was probably yung NSAIDs, yung pain medications natin. Those are the ones that cause allergies and propofol, diba? Which we test for. Everything, parang as Butch said, yung mga inhalational allergy, I've never seen. And in the literature, it's so rare. So I think it's just a mislabeling and something we have to go on the bandwagon of a national tour. Anesthesia allergy, ano ba ang totoo? Diba? That's for the next webinar na.
Yeah, I would like to add something to that, no? Because I'd like to bring out an aspect of anesthesia which is associated with adverse reactions, and that is malignant hyperthermia. This is associated with certain inhalation halogenated agents. And when these patients are given these anesthetics, they develop, their metabolism goes into very high gear, so that they deplete the oxygen, they become very
acidotic,
high fever, and eventually the whole body collapses from the cellular hypoxia. So this is associated. How do we elicit or prepare for possibilities like this? A very good history, we would ask, meron ba sa kamag-anak mo ang namatay na na-anesthesia? Okay, that's one thing. Then the other one is to look into certain regions where they come from. This is something epidemiologic, that malignant hyperthermia concentrations in certain areas of the country. So those are things that you can look out for, or an aborted anesthetic that did not take place because the patient developed fever or hypertension on induction of the anesthetic. So those, I want people to be aware of the possibility of a malignant hyperthermia resulting from an anesthetic. Thank you.
So, Boots, what parts of the country do you see a higher incidence of malignant hyperthermia?
From our history in PGH, because we were the first who detected it in PGH in the 1970s. The parts of Batangas, Cavite, southern. Southern.
That's very interesting.
Yeah.
Very interesting. Yeah.
So kung Batanggenyo ka, ano na, ingat.
Titingnan na, pasalitain mo muna, tinan mo ang punto. Okay. We have a question here on the chat. Raymond, have you seen this?
Yes. One more question. From
go
Nita
ahead.
Gregorio po. And this is for Dr. Kamagay. After I heard you, I became concerned with babies who undergo organ transplant, wherein the operations are usually 8 to 12 hours. Could that be the reason why some of them have behavioral problems?
Yes, that's one aspect, because it's more than 3 hours. Plus the fact that their metabolism is, how do you say, change, and then the attitudes around of the people around these transplant patients is also distorted. So you can, all of this contribute to behavioral problems, plus the possibility, of these patients being exposed to hemodynamic changes, hypoxia, ischemia, and they are placed in ICUs post-op, and prolonged confinement in ICUs with ventilation and sedative drugs, which are also amnesic, to keep them quiet while they are under ventilation. All of this can contribute to neurobehavioral problems afterwards. I hope, Mita.
Oo. So let's
Yeah, but sorry, can I, because I've
Go,
given
go.
Go ahead.
anesthesia for
Grace.
liver transplants for pediatric patients. It's a you have to risk benefit ratio. We have no choice but to give anesthesia to correct the problem. So it's not just anesthesia. It may be one of the causes for neurobehavioral problems, but as Dr. Camagay said, it's multifactorial. So, but we just have to be cognizant of it, that anesthesia really affects the brain. So we always have to, if you may have choices as a parent and you want your child to have oral rehab every year, you might as well think about it if it's worth the risks as well. Because anesthesia is not without risks.
Yeah. I have something again on my phone. Very interesting. My mother said she's forgetful because she delivered 8 babies under general anesthesia.
Mhm.
Would you
Okay.
comment?
I can comment on that.
Yeah.
We undertook a study with psychologists in the 1980s. In fact, it won first prize in the UP College of Medicine contest. We undertook a study to find out if anesthesia is associated with memory loss. What we found out is we took out all the known amnesic agents like the benzodiazepines, thiopental. We took them all out. And we found that there was no memory loss when we took out all those amnesic agents. And in delivery, a lot of the agents are given by the obstetrician. And a lot of them are amnesic agents. Benzodiazepines, some degree of propofol now. So as far as we're concerned, if you take out the amnesic agents, if you take out periods of hypoxia, there is really no memory loss. But there are some studies which say that the possibility of memory loss in pregnant women or in maternal conditions is that there is the production of oxytocin, high productions post-delivery in order for the uterus to contract. And studies have shown that in rats that high levels of oxytocin result in memory loss in rats. I don't know if you can translate it to human beings. It could be the oxytocin.
Yeah. I think in the 50s and in the 60s, am I correct? They were using general anesthesia more for delivery, no? For childbirth. Later on, nung nagkaroon ng epidural, tsaka na nagkaroon na ng iba, hindi na knocked out yung pasyente. I think this was more that's why this person who told me, her mother said. No, so, but I think nowadays, there are many options for anesthesia for delivering a baby.
It must have
that's right. That's right. That's right, ma'am. Dati, they used to give Ativan, remember?
Ativan is
yes.
Oh my goodness.
Oh my talaga.
Nakakalimot yon. Tsaka the caller could have been from my generation kasi there are 8 children. Ngayon wala nang nag-8
Wala nang ganon. Wala na nga. Oo. Kaya nga sabi ko 50s, in the 50s siguro ito, in the 50s and the 60s, no? So anyway, okay, do we have another question, Raymond? We're coming close to the top of our hour. Maybe, yeah, if you have one more question, Raymond, let's go.
Oh, sorry, nakamit pala ako. No more questions, Dr. Susie. We can go to the fun quiz questions.
Let's answer the fun quiz.
Yes, okay. Sige, well, I'll call in one of the speakers to help out with this. Although madali lang naman po siya. Can we have the fun quiz on the screen? Oh, thank you. Okay. I'll need the help of Dr. Lon for the first two questions. What are the different types of anesthesia, sir? Because this is from your presentation.
Yeah. Okay, so the choices are local, monitored, regional, and general. No? So I think, and all of the above. So the correct answer would be E, all of the above. No? Yeah, although when people say anesthesia, technically many will say na general anesthesia. Kasi local anesthesia, di ba, parang there's no sedation or anything. For me, anything that will make you undergo any type of surgical procedure or diagnostic procedure, and then that would be anesthesia. So E would be the answer. Yeah.
Thank you, sir. And then for our second question, kayo pa rin po, what are the side effects of anesthesia, sir?
Yeah, so the side effects mentioned, all of the above. Yeah, so usually grogginess is one of the things that you experience. Really a very common side effect. No, I'm glad no one mentioned nausea and vomiting. So that's a very serious side effect which so I think maybe that shows that very effective ang mga measures natin to prevent nausea and vomiting. So the answer again would be D, all of the above. Thank you, Raymond.
Thank you, Dr. Lon. For our last question, it came from Dr. Camagay. In an infant undergoing surgery, the least anesthesia is best because? Dr. Camagay?
The choices are A, infantile brain does not feel much pain. No. B, anesthetics depress the immune system. No. Anesthetics suppress CNS development. No. So the correct answer is D, none of the above.
Okay.
Thank you so much. Thank you so much. So at this point, we'll be asking our audience po to answer our evaluation poll. But in the meantime, while I'm going through the list, I'd like to urge all three of our speakers to take this time to come up with your final messages to our audience, maybe 1 minute or so, something that you'd like the audience to remember from your presentation po. Before that, we'll move on to our evaluation poll. Our evaluation poll, 5 questions, 4-point Likert scale. It reads, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. We do not send out a separate po na evaluation poll. Ito na po iyon. So hopefully everyone will be able to answer this evaluation poll. We will also not be closing this until the end of the webinar as we move on to the final messages from our speakers. Dr. Susie?
Thank you very much, Raymond. Okay, so we go to our closing remarks and we'll start with Dr. Grace. Grace, go ahead.
Okay, generally, I'd like to say that anesthesia is a physiologic trespass. And this message is for mostly the anesthesiologists listening, that since it is a physiologic trespass that we have created to be able to make surgery happen, it's our responsibility to be good at what we're doing, to be up to date, and to make sure and to assure patient safety. Thanks.
Thank you very much. That's Dr. Grace HERBOSA, Chair of the Department of Anesthesiology and Professor at UPPGH. Okay, let's go to Dr. Boots Camagay. Boots, go ahead.
I would like to appeal to our audience to consider anesthesia as a science, not a technique. It is a science, and that we, the proponents of this specialty, are open to discussion with you. We are not God. So we would like to discuss with you, share with you our fears as well, and arrive at a consensus that will make the anesthetic for you or your patients a well-delivered, scientifically based one. Thank you.
Thank you so much. That's Dr. Boots Camagay, also from the Philippine General Hospital. Let's go to Lon, Dr. Lon MANGUBAT. Lon, go ahead.
Thank you very much. So I think Grace and Butch said it so very well. No? Very good messages. What I would just like to add is that despite all your fears or your anxieties about undergoing anesthesia, because of our training, we have kept it very safe for you. So we're going to promise to take care of you. So we look in the eye, talk to you, as Butch said, get to a consensus of where we want to be, what you're going to expect, but we want to put you to sleep, wake you up, and hopefully have good outcome. So that's my message. Thank you.
Thank you very much. I'd like to thank our speakers for their time and the effort that they put into coming here, making the presentation, and being with our audience who truly appreciates your participation in the webinar. Okay, we will have a Raymond, do you want to do the panel results, or I'll call our closing speaker now?
Let me just
go to the poll results. Sige, go
okay,
ahead.
so far we've had at least 60% of our attendees answered the poll, and at least 91% of those who have participated indicate that they strongly agree, and it shows that the presentations have been well received and a deep appreciation of the knowledge that has been and perspectives that have been shared by our speaker. So maraming salamat po, Dr. Mangubat, Dr. CAMAGAY, and Dr. HERBOSA, and congratulations to the Department of Anesthesiology, the Philippine General Hospital. We can intro our closing remarks, speaker, and synthesis, Dr. Susie.
Okay, let's go. So we have a brief synthesis and closing remarks from PGH Coordinator for Training at PGH, Dr. Dion Sakdalan. You've had her before with us. So Dion, take it away.
Good afternoon, everyone. Can you hear me clearly, Doc Susie?
Yes, go ahead.
All right. Thank you again, Doc Susie and Doc Raymond, and good afternoon. This afternoon, we hold our 136th episode of Stop COVID Deaths with our webinar title, Gising Na, Masarap ba ang tulog mo? So as always, we had a very fruitful and interesting presentation and discussion of the topic of general anesthesia and new developments on how to put patients to sleep for a medical procedure, its benefits and after effects. So we'd like to thank, on behalf of the team, our distinguished panel of UP College of Medicine professors, who are also anesthesiologists from the Philippine General Hospital. So our first presenter was Dr. Lon Mangubat, who presented the commonalities and differences of general anesthesia and sleep and the risks and complications of general anesthesia. So he talked about the stages of general anesthesia, which are induction, maintenance, and emergence. And he explained to us that patients on deep general anesthesia are in a state of coma. But unlike coma due to trauma or any brain problems, it is coma that is controllable and reversible. He emphasized this state of deep sleep is necessary for our surgical procedures to be done efficiently and effectively. He reassured us that their responsibility as anesthesiologists is to monitor the patients closely and to adjust the meds and gases given to the patient on anesthesia so it will be safe for them and to minimize the complications. He also talked about the side effects of GA or general anesthesia, which include sore throat, chills, shivering, headache, nausea, vomiting. Some would have muscle pains as well. But this can be managed eventually if ever they occur. His final message was to know your anesthesiologists. Get somebody whom you can talk to, be comfortable with, and can work well with your surgeon. Our next presenter was Dr. Boots CAMAGAY. She talked about general anesthesia for children and its after effects on the developing brain. She emphasized that putting babies on anesthesia to limit the perception of pain during procedures is already standard procedure. She said that approximately 6 million babies, neonates, newborns undergo anesthesia per year. Nowadays, they can already give anesthesia to the unborn baby, those still in the womb of their mothers, which brings the question of its possible effects on the developing brain. Dr. CAMAGAY mentioned 2 prospective studies that demonstrated that single, relatively brief exposure to anesthesia was not associated with neurobehavioral adverse effects. However, she also presented the US FDA communication statement that for lengthy procedures, like more than 3 hours, or repeated use of GA for kids less than 3 years of age, they may still affect, or GA may still affect the development of the brain. Thus, these exposures should still be minimized as much as possible. Finally, our department chair in the Department of Anesthesiology, also a professor of UP College of Medicine, emphasized the importance of the consent process that anesthesiologists and even patients should really value. Value this consent process and carefully undergo prior to a procedure so that the expectations of the patients may be leveled and that the anxieties may be allayed, and the anesthesiologist can also clarify misconceptions prior to the procedure. She reminded and reassured us that being under general anesthesia is similar to being unconscious, but it is completely safe because the anesthesiologists are there at bedside or beside the patient, and they are there to monitor and take care of them. She also talked about more advanced ways of monitoring patients while on general anesthesia, not just watching the blood pressure, heart rate, respiratory rate, but also the brain activity to ensure the safety of these procedures. Indeed, this very critical process of putting patients into deep sleep or in a state of controlled and reversible unconsciousness needs specialized medical skills and knowledge. Thanks to our anesthesiologists, giving GA has been standard procedure, not just for adults, but also for children and neonates. General anesthesia is safe, and complications may be minimized in the hands of competent and experienced anesthesiologists. Thank you very much once again to our presenters and reactors. Back to you, Doc Susie and Doc Raymond.
Thank you so much, Dion. Ganda kami ng synthesis ko, Dion.
Thank you, Dr. Dion.
Galing. Okay, so next week, we are going to have the Department of Family and Community Medicine, and they are going to bring us some very interesting cases about health problems inside families and family approaches. So be with us next week. Maganda ito, Department of Family and Community Medicine. Raymond, over to you.
Thank you, Dr. Susie, and thank you, Dr. Sukdalan, for that succinct but really malaman po synthesis and closing remarks. Before we conclude our program, all Stop COVID Death webinars are archived for viewing at the TVUP YouTube channel. For your convenience po, kasabay po nito, yung pong mga short videos po natin called SCD Shorts. If you go to www.youtube.com/TVUPPH, you'll be able to see ito pong mga SCD shorts, the one that's being flashed on the screen, as well as yung ating kabuuan, 135 episodes, but after today, it will be 136 webinars that you'll have access to. And almost 3 years, we're coming up to our anniversary pretty soon, and hopefully we'll be able to get more and more of you to join our credible online community. So this formally closes our webinar for the week. Makita-kita po tayo ulit next week from 12 noon to 2 p.m. It's a date.
Together, we can stop COVID deaths.
So keep safe, keep healthy, and see you online.